there's an interest in what I call targeted focal therapy. People call it focal therapy. I like the word targeted because you want to go after something. Mm-hmm. And I think the hardest part of this thing is not how you eliminate the tumor. There are multiple ways to do that. You have cryotherapy, you have heat, you have seed implants you can put in, you can put alcohol in, my gosh. But it's finding where the tumor is. There are a number of places around the United States that are using MRI as a way to determine what the target is for focal therapy.
Yeah.
And I think it's somewhat controversial, but what are your thoughts on that?
Well, it is actually a three-step rocket. The first step is do a good interpretation. The second step is hit it with a needle with biopsy, and the third step is hit it with a needle to put in heat, cryo, ice, or whatever, IRE. So also the complexity and the knowledge you need to have with the technology and how it looks at the image is very important. I see too many places around me that do not have yet enough experience in reading MRIs, and yet they are already jumping into focal MR-directed therapy, which of course gives no good results. So that is a warning. When you do it right, I think yes, but still we need to prove in larger trials whether this is the way to go for. Well, what are my thoughts about focal therapy? Focal means directed therapy, image-guided. I think yes, this is the way to go for. And I'm copying actually everything what I'm doing in prostate from breast. The screening, the detection, the manogram, the mammogram. So there are many parallels. Laszlo Tabar, he's a breast radiologist. He calls it the brother and sister tumor. So also with the breast, we had a time where we did a gross mammectomy. We really radical mastectomy. We removed everything, and now we are going towards tumor-directed therapies. I think in the prostate that will be the same in the future. We will, based on good technology and good handling with the technology, that's also important. In the future, we will do less and less, more aggressive, total prostate removing therapies. But I may be wrong. Are we there yet? No, we're not there yet, but there are some promising results.
What you mentioned about breast is very interesting for our audience. Those of you that haven't read, there's a book called The Emperor of All Maladies.
Yes,
and
I read
it goes
yeah.
through the horrible things that happen in breast cancer with the Halstedian things, and then Bernie Fisher's trying to do the lumpectomy and that. And I think we're sort of that with prostate in a way right now of just directing therapy, the male lumpectomy, I call it, and we've done probably 600 or 700 of those. But what one of the things we do are called mapping biopsies. We go transperineally, 5-millimeter intervals. We go through the prostate. We may do 180 biopsies on a large prostate. The average is about 80. And we sometimes have to shoot 3 needles through to get, because the needles are only 17 millimeters. And so we'll do 3 of them, we'll mark them. But we've shown in about 60 radicals I've done on men that have had this, that it is a needle prostatectomy, seriously, that the correlation of this with a radical prostatectomy is 1-to-1. As a matter of fact, we found some higher grade cancers, very small ones, that were missed on the whole mounts. Mm-hmm. So I think that it's, the whole thing about the mapping biopsies and the targeted therapy is finding where the cancers are. We feel pretty confident about that. But we have seen some failures, and the failures have been close to the seminal vesicles, the bladder neck, the apex, where we probably weren't aggressive enough.